We do a lot of research on obesity. We have several interesting ways of managing obesity and treating obesity, specifically endoscopically. Our group has come up with a variety of different ways to basically reduce the size of the gastrojejunal anastomosis, which is the connection between the gastric pouch and the small bowel that's created at the time of Roux-en-Y gastric bypass. We focus on a variety of different techniques to reduce the size of the gastrojejunal anastomosis, or stoma, endoscopically. Several of these are based on a variety of different endoscopic suturing techniques or plication techniques, and more recently we've been doing a lot of argon plasma coagulation for ablation therapy of the outlet. So this particular work looks at basically comparing the endoscopic suturing, which has really become probably the most widely accepted technique, to argon plasma coagulation, which is a newer technique that few centers are doing around the country and around the world. We prospectively enrolled patients who were undergoing endoscopic therapy for weight regain. And we basically, some patients underwent the endoscopic suturing, and many others underwent argon plasma coagulation. And so we were interested in looking at percent excess weight loss following these procedures at both 3 and 6 months and comparing them in that regard. And then also looking at differences in adverse events and total weight loss that occurs over the study period. Many of these patients have been enrolled and will be continued to be followed for several years. And so we have even longer term data now than we did, I think, at the time that this was all submitted. What we basically are doing is, with the endoscopic therapy, with the suturing technique, we go in and basically place sutures around the gastrojejunal anastomosis after a light ablation with argon plasma coagulation. And then we secure a suture around an 8 to 12 millimeter balloon. And so we reduce the size of the gastrojejunal anastomosis from over 20, sometimes over 30 or even 40 millimeters to a size of between 8 and 12 millimeters. And we follow these patients prospectively. In the argon plasma coagulation group, we go in and instead of using an endoscopic suturing technique, we basically cauterize or burn the gastrojejunal anastomosis with discrete contact argon plasma coagulation. And we similarly follow these patients prospectively. Both groups undergo the same diet and weight loss management plan following their procedure, including usually 6 weeks of liquid therapy and then 2 weeks of soft solids, transitioned ultimately to a diet that we have developed with our bariatric nutritionists. And we basically have them come to the office at 1 month and then at 3 months and then again at 6 months, and we have compared their differences in outcomes. We found that patients who underwent endoscopic suturing had greater excess weight loss at 6 months than patients who underwent argon plasma coagulation. Interestingly, at 3 months, we didn't really see those differences, but we suspect that a component of it is the durability of the technique of suturing. In the argon plasma coagulation group, we also we have them undergo repetitive sequential sessions until their outlet measures the same size as what we had done for the endoscopic suturing group, to a size of about 8 to 12 millimeters. So oftentimes the endoscopic suturing is sort of a one-time procedure, whereas the argon plasma coagulation occurs over every 2 to 3 months until their outlet size is the size desired. I think we, in some ways, anticipated that endoscopic suturing would have more durability and greater excess weight loss and total weight loss than argon plasma coagulation. I think probably the things that were more surprising to us were the predictors of weight loss. And what we found is that, and consistent with previous studies as well, that the amount of weight that you lost prior to your gastric bypass was really probably the single and best predictor of how you did following endoscopic therapy. We also found, which we thought was surprising, that men tended to do much better. The cohort that we were studying was predominantly women, probably in the 88 to 89% range. But of the 10 or 12% of men who underwent our procedures, they lost profound amounts of weight. And we're not exactly sure why that is. But interestingly, someone else from this meeting was presenting their work and similarly found that men tend to do better following these procedures. So I think it's something interesting and something that we'll look into in the future. With Endoscopic suturing, we require a one-night stay at our hospital, and mostly that is because we really want to be aggressive at controlling nausea and vomiting following the procedure. The procedure itself entails really a one-time suture that's placed in purse string fashion around the gastrojejunal anastomosis and then secured. And so secured following balloon placement. So we secure it over an 8 to 12 millimeter balloon. And we know that patients who are nauseous and vomiting after the procedure or retching are at great risk of basically bursting that suture. And so we have them stay for one day. So most of the time people who undergo endoscopic suturing complain of some nausea, some vomiting. We try to control that aggressively with IV antiemetics. And then occasionally they have some discomfort as well. The majority of people actually do quite well, and usually only these complaints only last for about a day or so. Argon plasma coagulation is a sort of newer method where we're using contact burning at the site of the anastomosis, as I've mentioned. And so patients sometimes complain of some pain. They complain of less nausea and vomiting than with the endoscopic suturing. But I would say their major complaint is probably discomfort. But again, it's very well controlled, and we do not keep them in the hospital for a day following the procedure.